good afternoon, everyone, and thank you for joining us. My name is Dr. Steph Kershaw, and I'm a postdoctoral research fellow at the Matilda Centre for Research in Mental Health and Substance Use. And I'm located at the University of Sydney, and I'm also the project coordinator for Cracks in the Ice online toolkit. So it's my really great pleasure to welcome you to today's Cracks in the Ice webinar. Now, before we begin our webinar, I would just like to acknowledge the traditional owners of Australia and recognise their continuing connection to land, water and culture. I'm currently on the land of the Gadigal people of the Eora Nation, and I pay my respects to their elders, past and present. And I also further acknowledge the traditional owners of the country on the land on which you are and pay my respects to their elders. So today's presentation is one in a series of webinars, which will be focused around methamphetamine. And this is running as part of the Australian Government Department of Health funded project, Cracks in the Ice. So if you haven't already visited the Cracks in the Ice website, I would encourage you to do so. And we welcome any comments or suggestions that you have. So feel free to get in touch with us at any time. Before I introduce today's speaker, I just wanted to let you know that as participants, you are in listen-only mode, and this means that we can't see or hear you. However, you will notice that you have a Q&A button on your dashboard, and this is where you can type in any questions that you have during the webinar and send them through to us. And then we will have a question and answer session at the end of the webinar. I'd also like to let you know that we are recording today's session, and we'll be making the recording as well as the slides available to you on the Cracks in the Ice website. Now, before we start, we also just want to get a gauge on who is with us today. So I'm going to launch a poll, and it's just a very simple one asking around, what is your profession and how would you rate your knowledge of cardiology? And so this is just to help our presenter so she can gauge and not assume too much knowledge of things. If you're like me, I'm hoping it's going to be quite basic and not too much Q-wave excitement. So just getting in the responses now. I'll give a few more seconds, even though it's quite awkward. All right, and while that's still running, I'd just like to introduce you to our presenters for today. So I'm very, very pleased to introduce you to Dr. Elizabeth Peratz. She's a cardiologist who's published extensively on the interaction of methamphetamines and the cardiovascular system. Dr. Peratz graduated from Melbourne University in 2010 with honours in her medical degree and gained a fellowship of the Royal Australian College of Physicians as a cardiologist in 2017. And she currently holds a co-founded NHMRC NHF postgraduate research fellowship, as well as the RACP JJ Billings Scholarship and the PSA Cardiovascular Scholarship. So you can tell that she's already amazing. Alongside her clinical work in cardiology, Elizabeth also spent 1 year in laboratory research in London, investigating biomarkers of pulmonary hypertension, as well as a year of postgraduate biostatistics study at Harvard University in the Global Clinical Scholars Research Training Program. Dr. Peratz also travels annually to Timor-Leste as a volunteer cardiologist with the East Timor Hearts Fund. So thank you so much for joining us today, Dr. Peratz. We're really lucky to have you. I'm sure it's going to be an interesting session. I'm just going to end the polling now, and I'll just quickly share the results. So with us today, we have around 27% of nurses, along with 12% of counsellors, 17% of AOD workers, some case managers, and a few other groups of people. And in terms of rating of knowledge of cardiology, excellent. It's between beginner to average, which makes me happy because that will help me as well. So thank you, Dr. Peratz. I really look forward to hearing your presentation.
Thanks so much, Steph. I'll get started, and thanks to everyone who's dialed in and also for doing the poll, because in preparing this talk, I was very unsure of not wanting to make it too cardiac, whereas everyone's expertise is going to be more on the methamphetamine side of things, but also then not wanting to sort of, teach everyone from the beginning again if everyone's expert in cardiac things. So hopefully this talk will sit at about the right level, But it would be great to also get feedback and to learn from all the expertise in the audience about the issues around methamphetamines from the non-cardiac side. So I thought in terms of the structure of today, it would be useful first maybe just to start briefly with a case study who's fairly typical of the patients we've seen on the cardiology ward. And then just to talk through the spectrum of methamphetamine-related cardiac complications that we've observed in our hospital and also around Melbourne over multiple hospitals over really the last 10 years. And then to drill down particularly to look at methamphetamine cardiomyopathies, which are a really unique entity that's becoming more and more apparent as one of the major adverse complications of methamphetamine use. And unfortunately, Australia is probably one of the leading areas of research into this due to high rates of use. And then leaving quite a lot of time for question and answers, and hopefully also learning a lot from the audience and getting feedback. So just to start with a fairly typical case study. So this is a 42-year-old man, maybe a little older than a lot of our patients with methamphetamine use, but he'd been using methamphetamine for quite a long time, around 7 years at the time he came to our department. And apart from that, he was fairly well. He occasionally drank alcohol. He had previously been quite a heavy cannabis user. And he had some varicose veins on both legs and a mild acquired brain injury, but no other significant medical history. And not on any medications at the time that he first met our cardiology department. And he presented to the emergency department with severe peripheral edema, so swelling of the ankles, and was admitted under cardiology for further investigation and assessment. And I won't go into all the specifics of this, but this is his initial ECG, which I think was done in ED and was a reason he really went under cardiology rather than general medicine for further investigations. And in summary, it's a really abnormal ECG. So there's evidence of marked T-wave inversion laterally, probably meets voltage criteria for left ventricular hypertrophy, and there's a bit of a failure of progression of the R waves throughout the precordial leads, and all of these things together, the kind of the vibe or the sholt you think looking at this ECG and being told this is a young person's ECG, is that this person probably has a cardiomyopathy, so a disease of the heart muscle. So we went on and did an echocardiogram or an ultrasound of his heart, and certainly this matches the ECG. And so for those who've seen the ultrasounds of the heart before, this is the main pumping chamber, the left ventricle here. And the key thing we can observe is that it's not doing much pumping at all. So those walls should be coming in on both sides and ejecting about 60% of the volume of the heart with each beat. And this is probably about 10 to 15% pump function we can see here. It's always a particularly bad sign when the valves look really mobile. It means you're seeing it by contrast with how much the walls are not moving. So this is one slice of his heart, and this is the same day, but just another slice where we can see his left ventricle, right ventricle, and his two atria. And again, we can appreciate, hopefully, that left ventricle, it's kind of big and globular like a sac, and it's just struggling as a pump. It's all thinned out and it's just quivering rather than doing any effective pumping. So this is a really bad heart for a 42-year-old man to have. So he was commenced on what really are the cornerstones of heart failure therapy, which I think probably most people in the audience would be aware that we have tablets like ACE inhibitors, beta blockers, aldactone and diuretics, given his peripheral edema to help offload the heart. And initially he did well. And so on our scoring system, he went from 4, which is the worst, to 2, which is that he can sort of do activities of daily life with a bit of breathlessness. And so that was quite an improvement. He also came off methamphetamines for a while, but then we saw issues with non-adherence to medical therapy emerge. Unfortunately, one of the complications of one of his tablets was that he actually developed breast swelling, which can be quite painful as well as cosmetically frustrating. And it was to the extent that our surgeons were actually considering offering him a mastectomy. So he had to stop the aldactone and didn't tolerate the alternative tablet we started, and then also just gradually stopped taking all of his other medications as well, and started reusing methamphetamines. And so in this setting, his symptoms worsened. Again, we saw on serial echocardiograms that his heart was just getting worse and worse, acknowledging though that there's not a lot of window for it to look worse than those first pictures, which are already very bad. And so he then came in as a cardiac arrest to our hospital, had multiple episodes of lethal arrhythmias, had to go to intensive care, then coronary care, and sort of was bouncing between them. There were lots of discussions. And this man is sort of representative of quite a series of patients we've had over the years like this, often people about 30 years old who are in a situation where their heart would require transplantation or at least device therapy, such as a defibrillator implantation. But there's been huge concerns about their ability to participate in all the complexities of transplant medications, transplant follow-up, and also the risks of device infection if they have, if they're immunosuppressed with a transplant or they have a defibrillator put in and then continue to use methamphetamines, whether that places either a device or a transplant at a very high risk of infection, which in itself would be very likely to be lethal and therefore would be doing them a disservice to do. And so ultimately for him, we did pursue a conservative trajectory of care where we didn't sort of refer for transplantation or offer a device, but did restart medical therapy and link him in with increased community supports. And actually he's been doing pretty well, quite amazingly, for about 2 years now since then, is still attending cardiology clinic and taking his medications, and has had some modest improvement of his cardiac function. And so this kind of then leads into what are the cardiac complications of methamphetamines and why do they occur? And probably everyone in the audience is more expert than me on this particular next few slides, but just to start with the real basics, methamphetamines are ultimately stimulant drugs, and they're sympathomimetics, so mimicking our adrenaline and noradrenaline. And they also block the reuptake of our monoamine neurotransmitters, so things like dopamine, noradrenaline, and serotonin. And they do that with sort of a double-edged activity by both increasing the release of those things into the synapse, but also blocking the reuptake, so that there's a double reason why there's more monoamines in the synapse. And those, of course, are the molecules that contribute to both a sensation of elevation of heart rate and blood pressure, and also emotional elevation as well. And so the sort of four, I guess, summary words for the impact of methamphetamines are that they're stimulant, anorexiant, so suppressing hunger, and can make people feel quite euphoric, but can also have some degree of hallucinogenic impact. And so the other issue is that when you displace all of those monoamines into the synapse, you then cause a net depletion overall. And so there's a need to go back and over time take increasing doses potentially to re-challenge that. And just to compare the extent to which they achieve that release of the dopamine into the synapse, it's quite notable, the difference between different sort of stimulants, and methamphetamines clearly have quite amazing impact on that. But this all comes with a host of issues because we shouldn't have such a profound stimulation of all of our neurons. And so while today is about the cardiovascular impact, my understanding from Steph is I think this is the 8th webinar, and presumably some of the other ones will touch on these other organ complications. And really methamphetamines are a real multi-system toxin that impacts the central nervous system, the lungs, the gut, the musculoskeletal system, can throw electrolytes completely out of balance. And of course, one of the biggest areas is its psychiatric side effects as well. But in terms of just the cardiovascular, you can see here, and this was first recognised around 14 years ago in the Medical Journal of Australia, that there's a lot of cardiovascular complications that we see. And so in summary, the methamphetamines will make us hypertensive, so increase our blood pressure, tachycardic, increase our heart rate. And with that, there's a risk of arrhythmias, so abnormal rhythms. And that risk is particularly increased if the heart has already been affected, so there's a cardiomyopathy. They can also contribute to some degree to acute coronary syndrome, so heart attacks, which we'll talk about in a few slides. And because we've increased our blood pressure so much, there is actually an increased risk of rupturing the aorta, the main blood vessel in the body. And that's a condition that's almost universally lethal, unless it happens right near a cardiac surgeon who can resuscitate you. You'll notice that one thing that's not listed as a cardiovascular complication here is the cardiomyopathy. And I think that's very interesting because 14 years ago, it wasn't really recognised. And as you'll see, there's really just been an incredible spike in the literature and increasing recognition, and really almost just the last 5 years of the issue of methamphetamine cardiomyopathy or weak heart muscle. And now we see it as such a prevalent problem in our methamphetamine users. So in 2015, again, we sort of put through we put together a table that summarised and focused a little more on the cardiac complications of methamphetamines, and this was published in our National Cardiology Journal. And some of the things are very similar to the MJ article, but there's more of a focus now on the methamphetamine-associated cardiomyopathies and the heart failure. And particularly, we can also see that there's different mechanisms by which each of these things are happening. So by increasing our heart rate and blood pressure, we provoke things like vessels squeezing shut, vessels ripping. But as we'll talk about in a few slides, there seems to be another mechanism of direct toxicity to the heart muscle, the myocardium, that's really responsible for the cardiomyopathies and providing a baseline for the arrhythmias to take off. And then there seem to be some people in whom there's a genetic mutation, a polymorphism, that interacts with when they take methamphetamines. They particularly develop problems in the lung circulation between the two chambers of the heart and really predominantly go into a right heart failure rather than overall heart failure, and develop a condition called pulmonary hypertension where their pulmonary blood pressures are really elevated. And it's thought that there's a particular sort of serotonin polymorphism that contributes to that. And then, as I've mentioned already, there's also just in people who are intravenously using methamphetamines, an increased risk of infecting, well, anything really, but particularly anything prosthetic, like a defibrillator that's been put in them. And those risks, of course, then go up again if they're co-ingesting with alcohol or other drugs, and they can interact or cross-inhibit metabolism. And then there's risks of dirty preparation as well. And so it's also important in the patient who's using methamphetamines and turns up with heart failure to make sure there's no other toxin that's involved also, with some particular micronutrient sometimes being associated. And as you can see, there's one case report of someone who actually developed manganese toxicity, causing their cardiomyopathy in conjunction probably with methamphetamines because their drugs were contaminated with heavy metals. And this is a paper that I really love and comes from Sydney. So hopefully Steph also loves it, but it's quite old now. It's 13 years old, but it's a big study that looked at about 370 patients who had died in relation to methamphetamines, not necessarily as the primary cause, but who had methamphetamines associated with their death. And then it goes through and sort of looks at the characteristics of those patients. And what it found, I think, is really quite shocking. So the first thing is that when we look just at the direct cause of death assigned by the pathologist, 14% of cases were directly related to cardiovascular complications. So in people using methamphetamines, about 1 in 6 of them are dying from heart-related complications, which is a big number and is really a big takeaway message, I think, that cardiovascular complications, if they're 1 in 6 people causes of death, I think it's reached the point where you would consider screening for them in your methamphetamine user patients. When we drill down more and say, well, what about the people who it wasn't necessarily the direct #1 cause of death, but on their postmortem examination, their autopsy, you found significant heart disease? Well, that number is even worse again. So 54% of the patients had cardiovascular pathology found. And it's worth commenting that's 54% of a population who have a mean age of 32 years old. So I don't have an exact number for what we'd expect in the average non-methamphetamine user 32-year-old, but it certainly would not be a 54% prevalence of cardiovascular pathology. And as you can see, it ranges, but for instance, 15% had severe coronary artery disease. And there's certainly increasing thought, although not good evidence or trials, but increasing thought that methamphetamines probably really accelerate the rate of production of or laying down of plaque that causes the coronary artery blockages and can lead to heart attacks. And so you can also imagine if you've got severe coronary disease and then you take methamphetamines and you really increase your heart's workload, you ramp up the blood pressure, ramp up the heart rate, that's going to make your myocardium, your heart muscle, struggle even more again. So you really put yourself in a situation where a heart attack is a high risk. And then we see all these other things like enlarged hearts and all kinds of other pathology. And so I think the sort of take home of this paper was really that cardiovascular complications as a cause of death are very common in methamphetamine users, and the prevalence of pathology is really high. And really far in excess of what we'd consider in the average 32-year-old. One condition we've seen that's particularly interesting is methamphetamine-associated malignant hypertension. So I thought it was worth touching on in just a few slides because it's different to other hypertension, and it benefits from being managed a little differently and approached a little differently. And so the mechanism that's thought to underlie it is that methamphetamines or other sympathomimetics like cocaine, they really cause your blood vessels to squeeze. They act on your alpha and beta adrenoreceptors. So if you now give agents that are going to cause them to really squeeze, you can cause unopposed excess of the alpha part, and you can cause them to actually squeeze even more. And so, for example, in previous studies, people have tried giving beta blockers to relax these really strong squeezing agents. And if you give a beta blocker on its own and you don't give any alpha blockade, then you can actually make the situation worse. And there was one study, this study is from the 1990s. I don't think you would ever get ethics approval today, at least not in Australia. It was done in Texas. But there were patients who were having a coronary angiograms. They had pressure measurements in their coronary arteries. Now, first given cocaine as part of the trial, and then they were given beta blockers. And they showed invasively with pressure monitoring that, yes, giving beta blockers, which is usually quite a standard management of hypertension, does worsen the degree of hypertension if the cause is cocaine or methamphetamines. And so this has led to a major suggestion being that in a patient who uses methamphetamines and comes into, say, emergency with malignant hypertension, and malignant hypertension is a particular condition which we usually sort of define as being sort of blood pressure over 200 or really strong symptoms like blurred vision or a headache, that rather than reach for the beta blockers immediately, it would be a good idea to maybe actually give them a small amount of benzodiazepines and also to give them alpha blockade. So an alpha blocker to try and relax that part of the squeezing, which seems to be the predominant mechanism. And so this has led to specific recommendations for cardiovascular-related amphetamine toxicity when it's hypertension. And so these are sort of either alpha blockers or vasodilators that don't involve any beta blockade, and also a degree of sedation or just observation, and if they're not too unwell, and watching them and let things wear off. And so, again, this was sort of incorporated into our article and guidelines back in 2015 in terms of sort of the workup and the approach to trying to treat the complications of methamphetamine use. But the big thing I sort of wanted to touch on today was methamphetamine-associated cardiomyopathy, because I think it is really fascinating, and not just fascinating as in it's rare and unusual, but as in it's common, and we should be screening for it. And so it first probably started popping up. Sorry, I haven't put a reference on this slide down the bottom, but I think this is from about 2007, this article. And it was really case report level. As you can see, this is 2 people who had used methamphetamines and turned up, who were young and had turned up with severe heart failure. And this was able to be published as a case report then because that was such an unusual thing to see. And so there was this spattering of reports. This one, is from 2007 as well, and said, we've got all these patients who are under 45 in Hawaii turning up with significant cardiomyopathies. And it was starting to get put together. And so then there were some studies with a bit more, I guess, maybe statistical rigor behind them where they compared them to age-matched controls. And they found that if you looked at all these young patients turning up with heart failure and took a good history, a good drug use history, 40% of the young patients with cardiomyopathy were abusing or were using methamphetamines compared to their age-matched controls. And then the other important thing was that the people who were turning up with heart failure who had a history of methamphetamine use also had much worse heart failure than young patients who were turning up with non-methamphetamine-related cardiomyopathy. And you can see it's about 10% lower the pumping function of their heart. So not only was it causing cardiomyopathy, it was causing a more aggressive cardiomyopathy for people. And what we've seen since then is that there's really multiple forms of cardiomyopathy it can cause. So cardiomyopathy is kind of an umbrella term saying the muscle doesn't work, and it can not work in a variety of ways. It can not work because it's gotten really big and floppy as a muscle, or it can not work and so it's kind of trying to overcompensate and it's gotten really thick and it's all the walls are increased, but it's still not working well. Or sometimes it can not work, but in a very reversible way where the heart still has normal size but is just acting very poorly, but can be reversed. And we've seen each of those patterns in methamphetamine users. And that sort of led to this publication in 2015 that wrote up a series of such patients in the forms of cardiomyopathy. But in terms of what provokes it, it's really been studied quite well in the 5 years since then. We're now starting to see some lab studies, which is really good to get first principles understanding of why people's hearts are failing when they use methamphetamines. And it seems to be, firstly, that combination of the sympathetic activation. So we're really ramping up our blood pressure and heart rate and almost using up our heart, what would be a lifetime supply in a few years. We're accelerating the aging of our heart. But there's also a degree of direct cell toxicity where our cells in the heart that are meant to be doing the pumping are getting poisoned, and all the messaging they're doing and the energy they're trying to generate pumping, all of those processes are impaired. And so over time, that leads to a lot of inflammation, a lot of trying to compensate by either thickening or expanding the chamber so you can fill more blood to try and pump that out. And over time, that leads to scar. And fibrosis is really a surrogate term for scar. If you've got fibrosis in your heart, that means you've got bits that don't have pumping cells in them. They've just got fibrous tissue, and fibrous tissue won't pump. So it's very a bad thing to have fibrosis in your heart. It means that it's probably not going to recover very well. And so these are just some images of what the different forms can look like and the different theories of how people have different sort of appearances. And so I guess in terms of just going back to that other one, as we said, the worst thing about the cardiomyopathy is that it appears to be worse in terms of all the other reasons you might have a cardiomyopathy. The methamphetamine users consistently in almost every study have more severe cardiomyopathies. Their hearts are working much worse. And then combined with that and thinking about our first case study, not only are the hearts working worse, but it's much more challenging to approach things like device support or transplantation in these patients due to sort of the background concerns about ability to participate in sort of quite rigorous, close, ongoing clinical care. And so the question, I guess, that really in terms of today's webinar, I just wanted to propose is, well, how do we pick up methamphetamine-associated cardiomyopathy? And for a range of people, not just cardiologists who are seeing patients using methamphetamines, but for community workers, nurses, emergency doctors, how would we sort of get worried that someone needs to be screened for methamphetamine-associated cardiomyopathy? And then the next question is, well, we've diagnosed it. Now, how do we treat it, and can it be reversed is the biggest question. And so the first thing, I guess, is just to ask your patient if they've got any symptoms that suggest a cardiomyopathy. And the things that we would think about would be shortness of breath, chest pain, dizziness, or swelling of the ankles. And if the patient who's young, like 30 years old, has any of those symptoms and uses methamphetamines, I think that's enough to then proceed to some form of testing. And the simplest, cheapest thing you can do is an ECG, just an electrocardiogram. And so we undertook a project that looked at the prevalence of abnormal ECGs in methamphetamine users, but comparing them to age and gender matched controls so that we knew if that prevalence was in excess, because a lot of previous studies had just said, here are abnormal cases without providing sort of background data. And somewhat unfortunately, perhaps at St. Vincent's, we see a lot of methamphetamine users. So there were quite a lot of ECGs that we had the ability to go through. And we found some really abnormal ECGs. Some are just presented here. But in summary, these kind of all show the hallmarks of a cardiomyopathy and are extremely abnormal. The ages and genders you can see in the box on the right. And so to summarise what we found that 72% of methamphetamine users in our cohort who had an average age of just 33 had some form of ECG abnormalities. And the details are presented here. But in summary, there were sort of signs of ischemia or cardiomyopathy, or just sometimes remodeling of the heart. So chambers are much bigger than they should be. And that's sort of an early sign of cardiomyopathy. And of those who had an echocardiogram performed because of an abnormal ECG, it was a good pickup test, really. About 40% had significant left ventricular dysfunction. And so probably every year I would estimate we'd see probably about 10 to 15 patients with really, really severe LV dysfunction aged about 30. And so the key sort of things we want to ask are, is there, when we look at the echocardiograms, is there reduced pumping function? Is that not working? Has the heart remodeled? and are the chamber sizes normal? And is there any important other disease that needs intervention? As you can imagine, if someone happened to have some other issue like an abnormal valve and then they took methamphetamines on top of that, that would be a big problem and would give them much less baseline to work off and tolerate things. So the next question that sort of comes up, I think, as a clinician is, well, okay, you've taken a history from the patient, you've found out they've got symptoms, you've organised cardiac investigations, and these have shown a problem. Now what do you say to the patient when they say, well, is there any point stopping the methamphetamines, or has this just ruined my heart forever? How reversible could this condition be? And so luckily there are a few papers that we can sort of go to when having this conversation. And so the short answer is it is reversible in the beginning, particularly if it's picked up early. And there's lots, or there's at least multiple case studies of people using methamphetamines who've had a severe cardiomyopathy diagnosed that has then almost completely gone away with taking heart failure medical therapy, so the sort of tablets we discussed in the first few slides, but most importantly, stopping methamphetamines. I've personally looked after several patients who've had a really dramatic, great outcome. We don't, however, have a clear idea on what that window period is, at what point it tips over and it becomes irreversible. Probably the best idea we have comes from cardiac MRIs, which are a pretty specialised test, but they are the best test for showing us that fibrosis that I mentioned, the scar tissue in the heart. And if your heart is full of fibrosis, that will tend to imply that things may not be as reversible. And so this was an early case report of a patient who sort of had MRI guided therapy. But then we have an Australian publication as well from some of my colleagues at the Alfred. And so they just looked at 20 patients and the predictors of who recovered and who didn't. And perhaps unsurprisingly, if you had fibrosis on your MRI, that was a really not good sign in terms of the reversibility. And things that were good for reversibility were having a heart that was more structurally normal. So your chambers were still all the same size. It had been picked up early before the heart had remodeled and developed scar tissue. And so I guess just to comment further on that, this is, I think, a challenging thing in a way, because then there can be a reflex to think, well, I should just order a cardiac MRI on every patient who has a methamphetamine cardiomyopathy. But sometimes, and I'd be really interested in people's thoughts on sort of the ethics of this, but ignorance can be bliss. If you order the MRI and it comes back full of fibrosis, and your patient says, if I stop methamphetamines will my heart go back to normal, and you think it's very unlikely at this point, that can be very demotivational. And so often as a sort of department, we've had these discussions, we've sometimes elected to just hold off on the MRI because it will really just give prognostic information, but sometimes demotivational, and just start the heart failure therapy that we want them on anyway to give them their best shot. We want them off the methamphetamines anyway, and then do an MRI perhaps down the track in 6 months and see if there's an improvement from the initial echocardiogram. But sometimes finding a whole heap of fibrosis can be a very bad finding in terms of how you communicate that in the message. So as with our patient who was in that first case study, really the current standard of care for methamphetamine-associated cardiomyopathy, now that you've picked it up, is number one is abstinence from methamphetamines. Number two is appropriate anti-heart failure therapy. We're very lucky in cardiomyopathy that, in cardiology, that we have quite a lot of new tablets coming out that have excellent evidence base. So even in the last sort of 10 to 15 years, outcomes in heart failure have continued to improve, and they're just getting better and better. So hopefully medical therapy will continue to be superior in years to come. And then the more sort of challenging one is device therapy. So things like defibrillators that will shock the heart if the patient has an abnormal or life-threatening rhythm. And device therapy can be a real double-edged sword because sometimes a person might recover function and then you've sort of put an artificial device in their heart that they're not using and they don't need. That's not ideal, clearly. And then also there's a lot of concerns about if someone's injecting drugs, the risks of infecting that device. And defibrillators, just to sort of give an idea, are a bit different to say if you get an infected knee joint replacement where you can take it out and wash it out, even though that's a big undertaking. If someone has an infection on a pacemaker or defibrillator lead, that's really dangerous. Obviously, it plugs directly into the heart, but also you can't just pull it out like a knee joint replacement unless you risk taking a big section of heart tissue out with it as well. And mortality from that has been quoted at sort of up to 5% or so, depending on where it's done. So it's not something we take lightly, and really prevention is much better than any kind of curative attempt at surgery at that point. So this is why there's so much hesitancy about putting in things like defibrillators in people who are injecting drugs. And going back to the heart failure therapy, as I said, hopefully with the improvements in our heart failure therapy and tablets, we'll increasingly be able to offer tablets as equivalent to devices in the future, to our current level of success with device therapy. And so this is a nice paper from 2020, that's so quite recent, that came out, that again just sort of summarises an approach to management. I think it was in Circulation, but it sort of, I guess, just sort of says that your patient might present with tachycardia, hypertensive, or with sort of signs of a cardiomyopathy. And there's sort of expected things that you might want to think about, particular things you might want to hold off, for example, not giving beta blockers. And then in terms of their long-term management, all the things that you would want to think through. And so I guess in summary, methamphetamines cause a whole spectrum of cardiac damage, just from putting your blood pressure up and your heart rate in the acute setting to causing long-term heart failure. And so the key things that would be really good to know about are malignant hypertension, so really high blood pressure, and also the risks that creates for tearing your blood vessel as an almost overwhelmingly fatal experience. Accelerating the progression of coronary artery disease so that we see severe disease in quite young people. So if a 30-year-old methamphetamine user tells us they're having regular chest pain, that's not something we should necessarily be just reassuring them about. We should consider further investigations quite promptly. And a really severe cardiomyopathy or heart muscle failure that's worse than other forms of cardiomyopathy. And so what can we do as clinicians? I think that if we've got, as I said, if we've got a condition that is creating direct cause of death in 1 in 6 people who are dying who are using it, that really that's when it should qualify for a screening approach. So having a really low threshold to do cardiac investigations, I don't think an ECG in all people is unreasonable, given the high prevalence of pathology that we find, and the cheapness and non-invasiveness of an ECG. It is really important to just be aware in terms of management that sometimes there's management differences in how we approach things like a hypertensive crisis. And finally, the most important thing is that this is cardiology talk, but none of our long-term engagement with our methamphetamine use of patients would be possible without really extensive multidisciplinary involvement. So between the hospital and the community, between their GP and their cardiologist, between all the allied health and addiction support networks that we have, this is really the only chance I would say that we have of obtaining long-term support for patients, and everyone being sort of on the same page about what we think is the diagnosis, the prognosis, what our goals are in treating, and continuing to follow up with our patients to try and sort of encourage adherence to our recommendations. And so I think that brings us to about 20 minutes or so of the Q&A, which I presume Steph is in charge of.
Yes, I am, and I'm delighted to say that the questions have been coming in fast and are really interesting. That was a fantastic presentation, Liz. Thank you so much. I wasn't actually aware that the methamphetamine had so many mechanisms of action that would impact the heart and the cardiovascular system. I guess one of the first questions that's popped up is, do we know if the route of administration of methamphetamine has any impact on the level or speed of damage? So for example, if someone is injecting drugs, is that more likely to cause harm than someone who is smoking in terms of the heart?
So this is a really good and common question, and sort of a really intuitive thing to wonder, I think. And the answer is that we don't know. We don't have good trials. Pretty much all the studies have shown cardiomyopathy and methamphetamine users have been retrospective and haven't taken super thorough histories about route of ingestion enough to draw definite patterns. So the short answer is no, we don't have a clear thing, and there aren't sort of good animal studies where they've made little mice, not the mice inject, but you inject the mice, or made the mice inhale or anything. We don't have that level of evidence, but we do know that certain routes come with certain other risks. So injecting comes with the risk of bloodstream infections, particularly. Inhaling can be associated with more of the pulmonary complications, more lung damage. So that, I guess, is sort of the thing that we do think about more, that we might screen the lungs more in someone who exclusively is smoking, things like that.
Oh, okay. Well, that makes sense. So it's kind of a bit of both in a way. Need a bit more information, but also the route of administration does lead to different effects.
I think also I always personally ask about route of administration and document as well. Yeah.
Is the length of use or level of use the greater contributing factor to the development? So if someone uses a small amount for a longer time, or if someone uses a large amount for a shorter time, what do you think is more likely to impact the heart?
So again, such a good question. And the short answer is I really don't know. And I suspect the main answer is genetic. There are some studies looking at people with different genetic profiles. And there was one that was really interesting where they said people who get the cardiomyopathy seem to also be more prone to psychiatric complications as well. So maybe they've just got this sort of vulnerability gene. We don't routinely test people genetically at all with methamphetamine cardiomyopathies because it's not going to change clinical management. But I would absolutely love to see if the people that we see who are 30 and turn up with this extreme heart failure have a similar sort of profile, in particular polymorphisms reported in the literature. That would be so informative to find out, because we've certainly seen people who've used methamphetamines really intensely but not for very long, and we've seen people who've used them just socially on weekends sort of for 5 years, so probably not. And then we see people who've used them extremely heavily in both directions, both intensity and duration, and have completely normal hearts. And so I really suspect those people have some kind of protective gene on some level. And so I think that probably the key thing is going to turn out to be your underlying genetics, and that will determine your vulnerability. And some people really can't handle their methamphetamines in terms of their heart.
Right, yeah. And I mean, that also, I guess, makes sense because we do know that methamphetamine is also can be genetically linked in terms of your risk of developing addiction as well. So I'm going to have to keep going through all these questions. They're coming through. If a mother is using methamphetamine during her pregnancy, do we know what the impact is on the heart of the baby?
That's a good question. Probably outside my area of expertise, I have to say. I've never looked after someone in that situation or sort of really investigated the literature there. I imagine that it could potentially really accelerate, create a risk for fetal cardiomyopathy, but I haven't seen any case reports about it or any things. It's a really interesting question.
Yeah, we did do a webinar on the impact of methamphetamine in pregnancy earlier, but we didn't really talk, or I don't even know if there's much literature around the impact of the heart. It was more around the impact on the mother's sort of blood pressure and heart rate that, could potentially affect the fetus and lead to early miscarriage.
It's a really interesting question. Obviously, there's bits of the fetal circulation that are different. Like you've got bits that are open in the fetal heart that close at birth and things. So in a sense, it's not having to work independently quite as much. But still the exposure and the direct toxicity that's sort of been hypothesised, certainly not good.
No. A clinician has a question about any comments or suggestions on early intervention approaches for those people working in AOD or addiction services. This person says that many of their patients don't have a regular GP and have limited engagement with health services in general. Is there any sort of links to patient or family information or resources that you know about that we could share?
Yeah, no, I don't think there's any sort of information as such beyond the scientific literature. I'm not aware of sort of, any handouts or anything like that. It's, I guess, in terms of community workers or AOD workers, things like asking about symptoms, but then if the person's not linked in with a GP and doesn't have a clear sort of primary care person, it is hard to initiate the whole ball rolling of appropriate tests and referral to a cardiologist for screening and things. I don't know of any patient handouts that are freely available. It's probably a really good idea. And I guess the steps, if there's concern, is just feeding into the broader thing that anyone with substance abuse really will always benefit from being linked in with a GP if it's at all possible. But sometimes it's very challenging to set that up and maintain long-term relationships.
Yeah. Now, are there any sort of specific questions that you think community workers should ask on top of the ones that you already covered today? Or
No, I think all good.
All good. Someone was also interested because methamphetamine is obviously part of the wider range of group of drugs called amphetamine type stimulants. And in that amphetamine type stimulants, there's the dexamphetamine and the Ritalin, which is commonly prescribed for ADHD. Do we know any literature around that, whether or not dexamphetamine or Ritalin impacts the heart, or is it mostly been in the illicit substance field?
So no, we do see sort of all amphetamine type stimulants can impact the heart, and certainly we do see Ritalin or sort of dexamphetamine cardiomyopathies in patients. I guess the difference, and sorry, just on that note, you can actually have something really simple called just a tachycardia-mediated cardiomyopathy, which is, if someone's got an overactive thyroid or their heart rate's just fast for any reason, again, probably genetic, but some of those people will not tolerate it and will develop heart failure, and other people will tolerate a fast heart rate with no issues at all. But so even just the act of having the fast heart rate for some people puts them into heart failure. And then sort of the step before that, what caused the fast heart rate, whether it was Ritalin or methamphetamine, all of those things can cause it. Probably the difference between methamphetamine and Ritalin, I guess, is that usually when we see people who are taking, say, dexamphetamine, it's a bit more therapeutic and prescribed and titrated. So it's not as much of a sort of wild toxicity over, a high level environment. There's not as much intense tachycardia occurring at a time. So we see it less commonly, but we certainly do see it still.
Okay, that's really interesting. And I guess also it comes back to methamphetamine being like an illegal drug that you're not sure how much you're taking, but you also don't know what it's been mixed in with as well. Yeah. So many questions. Are beta blockers contraindicated in those with pulmonary hypertension and normal systemic pressure?
So not necessarily, but as I sort of said, I would hold off beta blockers in the first instance until we've sort of worked out exactly what's happening with the patient and what's driving it. Not to get too technical, but pulmonary hypertension, particularly the kind that methamphetamine uses, pulmonary arterial hypertension, is a really sort of unique subset, and it's often best treated with pulmonary vasodilators that specifically act on that circulation, and there's specific classes of drug for that. So we do have a few patients at St. V's who've had isolated pulmonary arterial hypertension from methamphetamine use, but have normal systemic blood pressures, sometimes low even, and have isolated right heart failure. And they've been started on specific pulmonary vasodilator therapy and have really made huge improvements on that with pulmonary pressures returning to normal. There's probably two success stories, real success stories I can think of that come to mind. So the key point is really accurate diagnosis and delineation of what the pathology is, and then really targeted treatment.
Wow, yeah, that sounds, it's good to know that, you can have good management of these cases. It's not all doom and gloom. Someone also asked, if a patient presents with an extensive history of methamphetamine use and heart failure symptoms, would you recommend TTE or cardiac MRI in those cases?
So TTE being echo, transthoracic echocardiography, is always the first step. I don't think anyone would ever go to a cardiac MRI who hasn't had an echo first. And so I would say that I have a very low threshold for echocardiogram in those patients, and they should all have an ECG. And then if the echocardiogram is really abnormal, as I said, MRI is useful because it tells us probably about reversibility, and it's also the gold standard in terms of quantifying that pumping function. But it also raises a whole heap of questions about, if you find probably irreversible damage, how much you're going to be able to motivate people to stop methamphetamine use and things. So often, and there's also accessibility issues in a lot of hospitals with cardiac MRI. It's not an easy test to get. So echocardiogram is the cornerstone of investigation and monitoring, would be certainly the way I'd go.
Okay, that's good to know. And also another technical question, and I apologise in advance if any of these words are mispronounced.
No.
What about the use of Benzodiazepines in managing meth-induced hypertensive crisis, given that it blocks alpha-1 receptors as well? And this person also has a follow-up question. With diazepam, what dose would be push up to before adding replacing another agent?
So with Cavitolol, I think probably, so yeah, Cavitolol is sort of like one of the short-acting beta blockers, and it inhibits your alpha and your beta receptors. So it is a good, if you really must use a beta blocker, it's probably a good one to start with, and particularly in sort of the perioperative setting or something. In the longer term, there's another beta blocker called Cavitolol, which is particularly PBS indicated for people who've got reduced pumping function, like a lot of these methamphetamine user patients we're looking after. But it also does dual alpha and beta blockade. So if they've got a good systemic blood pressure, Cavitolol can be quite a good beta blocker of choice. It's got good evidence of helping to remodel the cardiomyopathies and reverse them, and they're PBS subsidised, and they do the dual alpha beta blockade. So that can be sort of a good thing to consider in the longer term. Regarding the diazepam question, so I have to confess that's usually sort of an emergency department administration. So in the short setting of the agitated patient who turns up with malignant hypertension and needs their blood pressure brought down acutely, we wouldn't be putting anyone on benzodiazepines long-term who's using methamphetamines, like in the cardiology ward or in the outpatients. This would be just for acute management in the sort of resus cubicle of a really massive hypertension. And so usually ED would just sort of, I guess, it would depend on if the person's previously had benzodiazepine issues or naivety, or if they're very tolerant, but would titrate it according to that by the milligram.
And I also have another question from someone who works in correctional healthcare and methamphetamine use. So methamphetamine use may decrease within prison, or your route of administration may change, but there's certainly still access to illicit substances within prison. Would you recommend ongoing ECG for those with a history of methamphetamines, even if a person is abstinent or reports being abstinent?
That's a really good question, because I think my answer would be yes, because ECG is just such a cheap and non-invasive test to do. And certainly, yes, if they've got any symptoms and there's a history. What we know from other toxin-induced cardiomyopathies, and I guess the classic one would be something like breast cancer chemotherapies, is that we do screen for cardiomyopathies from chemotherapy sort of while you're having the chemo, but there is also a subset of people, and again, this will probably ultimately turn out to be a bit genetic, but who turn up 10 or 15 years down the track, and they didn't have issues at the time, but now they've gone into heart failure with no other cause found, and it's thought that it was the chemotherapy that sort of had this legacy effect, and that's why we have follow-up clinics for late effects of chemotherapy or radiation therapy, because radiation therapy can also do the same thing, particularly the older ones where it wasn't as focused. And so in the same, if we extrapolate that to methamphetamine users, could they turn up 10 years down the track with heart failure? There's not probably a particular reason why they wouldn't. And I think certainly in terms of Australia, we've really seen a surge in methamphetamine use, both in terms of sort of the purity of it and the popularity in the last sort of 5 to 10 years. So extrapolating on that, we may see a surge of people turning up with heart failure in the next sort of 15 years that might be related. And so, yeah, to answer the original question, if someone's sort of in correctional health and they've either got symptoms or they've got a significant history of methamphetamine use, I think there is pretty much zero harm in keeping an eye on them symptom-wise and doing an ECG once a year at least.
Is the cardiac MRI covered by Medicare? Is that a question?
So it is under certain conditions, and probably I won't get all of these details right, but essentially if they're seeing a cardiologist and it's ordered within the hospital, then there should be no issues with it. I think that it would not be covered if it's ordered from the community by a non-cardiologist. And then there are certain conditions that sort of you specify that you're investigating to show that it's sort of a on-label MRI, so to speak, that you're using it to ask a focused clinical question. I think that, yeah, I won't guess at the cost of an MRI, but it's certainly many hundreds of dollars if it's not subsidised. And so you would want it to be subsidised, certainly.
Yeah. I think that sounds definitely want that to be subsidised.
Yeah.
If you are someone who is currently using methamphetamine and trying to get into recovery, what would you recommend for them? Would it be best for them to talk to their GP and see if they can get a referral to their cardiologist, or what do you think would be the most appropriate pathway if they are concerned about any heart issues?
Yeah, so I guess sort of a two-pronged approach. One, if they're concerned but not sort of actively concerned, then certainly your GP is your primary care sort of physician and a great person to sort of holistically put it together and do initial appropriate investigations. But at the same time, methamphetamines can be really toxic. We know they can sort of cause really bad heart failure quite suddenly and bad coronary disease. So if a person's got concerning symptoms, an emergency department is also an appropriate place to go. We certainly don't want to advise people who've sort of got active chest pain to be going to a GP who may not have, full capacities and things to treat it. If someone's actively concerned, they've got really bad symptoms, then emergency department is always the first port of call.
Okay, that's great advice. Thank you. From your experience and from the patients that you've looked at, do you see any differences in terms of certain populations being more affected than others? Do you think ethnicity might be one of those factors that puts certain people at risk?
We haven't probably had the big enough numbers. Like we've only had sort of a few hundred patients in our studies, which I think is probably, there's not enough ethnic diversity in those populations to be able to pull out, 5 people from a certain population and compare them to that. So yeah, we haven't really seen a clear ethnic pattern, but I'd be really interested in the community if people feel that they've seen a really strong pattern.
Yeah, well, someone was just asking about whether or not there were any findings that were different among Aboriginal and Torres Strait Islander people.
So in Victoria, we probably don't have the population big enough. In the Northern Territory, it'd be really interesting to know if people have seen differing patterns and things. But yeah, probably I think, less than 3% of our patients would be identifying as Aboriginal or Torres Strait Islander. So in terms of the numbers of patients we'd need to see with a methamphetamine cardiomyopathy to be able to statistically say definitely there's an increase, we haven't really seen that to this point.
Okay.
Yeah.
Yes, and someone just agreed with you that they would love to see a study from the Northern Territory. So I'm not sure if this is going to be a question you can answer.
Okay.
But what happens if a client has been on methamphetamine and they're given benzodiazepines, but they previously had an addiction to benzodiazepines? Is there any other medication that they could be given because of their history?
So as I said, the benzodiazepines use is really usually in the ED setting. And so it's really just sort of, over a few hours they'll receive those. To be honest, I'm not necessarily entirely confident that people will take an extensive history of previous addiction issues or withhold benzodiazepines if there was an issue and the person's currently unwell in resus and would benefit from a small dose. I suspect they would probably just give benzodiazepines anyway in that setting. But there is certainly, we can emphasise more the alpha blockade or just vasodilatory things like angioline infusions and things if there was huge concern that the person couldn't have benzodiazepines for any reason. And as I said, we certainly don't continue those on the cardiac ward or prescribe people benzodiazepines as an outpatient who are using methamphetamines. This is more just for the acute emergency department management.
Okay, yeah, that's good. And in your experience for clients who have found that they have cardiac issues, is that motivational in a way for them to remain abstinent or reduce their methamphetamine use?
So really binary, I think. Some people don't engage at all and have a terrible outcome, and that's really heartbreaking. And certainly, I've sort of talked about a few good cases, but I also remember some real tragedies, like 24-year-olds who've died of heart failure and just not engaged, despite really extensive efforts by everyone in their care team. And then there are people who are highly motivated and it is the sort of thing that's needed and they really commit and become completely abstinent. And I think there's 2 things that tend to make them really commit. One is if they are really symptomatic with heart failure, symptoms really cause people to change behaviour. They don't like feeling unwell, of course. The other thing is if we say we can't put in a device or we can't send you for a heart transplant if you're using methamphetamines because it could kill you in a different way with the risks of infection and things, that in itself can be motivational as well. So knowing they have access to every tier of cardiology support if they quit or become abstinent can be a huge driving factor as well.
Yeah, right, that makes sense. In terms of sort of the prognosis, how common is it to see people with lasting cardiomyopathy and other cardiovascular diseases many years, I guess, after they finished using methamphetamine or stopped using. Sorry, that's better.
Well, I guess that sort of comes back to the earlier question about do people develop issues down the track? And I think it's a really good question. And I don't think we really have a clear answer as to it. And particularly since everyone has, well, not everyone, but, you know, there's been a rise in use in the last 5 to 10 years. I wonder if in the next 5 to 10 years, we may see more of a spike of young people who've got cardiomyopathies and other cardiovascular disease presenting. And when a good history is taken, we find out there was a period of heavy methamphetamine use sort of years prior, but no current use that's provoking it. And in those people, then it will also be very interesting to see what their echocardiograms and MRIs look like in terms of, is it going to be less reversible if it turns up late and there's nothing to stop to help reverse certain things.
Yeah. Well, today has been fascinating. Thank you so much, Dr. Peratz. So many people have already sent through to say that it's been an excellent presentation, and thank you for being so patient with the many questions that came through. Apologies to anyone who didn't get their question answered. Please do feel free to email me and I can pass them along to Dr. Peratz if you'd like that. You're also more than welcome to get in touch with us at any time if you have any other questions or inquiries. We'll be putting on more webinars and new resources on cracks in the ice throughout the year, so I'd encourage you to subscribe to our mailing list to receive any future updates. Dr. Peratz, thank you again. That was really fascinating. We really enjoyed it and we really appreciate your time. Hope that you all have a wonderful day and thank you all for joining us.
Thank you very much.